Your parent drank 2 cups of coffee this morning, maybe a glass of juice with breakfast. They feel fine. They're not complaining of thirst. And that, right there, is exactly the problem I need to talk to you about today. Because here's what most families don't know, and what most doctors don't have time to explain in a 15-minute appointment. The thirst mechanism in older adults is fundamentally broken, not weakened, not slower, broken. By the time someone over 65 feels thirsty, they are already clinically dehydrated. The warning system that works perfectly in a 30-year-old simply does not fire the same way in an aging body. And the consequences of that silent, invisible dehydration are not just a headache or dry skin. They include urinary tract infections that cause sudden behavioral changes, dangerous drops in blood pressure that cause falls, acute kidney injury, medication toxicity, because drugs that are normally processed and cleared by the body build up to dangerous levels when there isn't enough fluid to carry them, and confusion so severe that it is routinely misdiagnosed as dementia. Today I'm going to show you exactly what's happening, what to watch for, and what your family can do about it starting today. Before I go further, if this is the kind of information that would help someone you know, share this video right now. And if you haven't subscribed yet, do it before you forget. Every week I publish content like this, specifically for families navigating the care of an aging parent. Practical, clinical, and honest. Hit subscribe and you won't miss it. Now let me explain why this happens, because once you understand the mechanism, the urgency makes complete sense. The kidneys of an older adult are less efficient at concentrating urine. This means more water is lost in urine even when the body needs to conserve it. At the same time, the total amount of water in the body decreases with age. Older adults have less fluid reserve to draw on in the first place. Add in the fact that many common medications are diuretics, blood pressure drugs, heart failure drugs, even some diabetes medications, and you have a body that is losing fluid faster than it realizes, with a thirst signal that isn't compensating, and a reserve that is already lower than it was at 50. This is not a crisis waiting to happen. For many older adults, it is a slow, chronic, background state of mild to moderate dehydration that most families never identify because the person looks fine, acts mostly fine, and never once says, "I'm thirsty." So what does it actually look like? Point 1. Confusion and behavioral changes are often the first visible sign. Not thirst, not dry mouth. This is the one that sends the most families to the emergency room unnecessarily. An older adult who was perfectly clear and oriented yesterday is suddenly confused, agitated, or saying things that don't make sense. Families assume stroke. They assume dementia progression. They assume a psychiatric event. In a significant percentage of these cases, the cause is dehydration. The brain is extraordinarily sensitive to fluid balance. Even mild dehydration, a loss of 1 to 2% of body water, measurably affects cognitive function in older adults. Concentration, short-term memory, processing speed, and orientation all decline. In someone who already has mild cognitive impairment, the effect is amplified. Here's what I want your family to know. If your parent has a sudden change in mental status, suddenly more confused, more agitated, more disoriented than usual, dehydration and urinary tract infection are two of The first things that need to be ruled out before any other explanation is entertained. You can say that exact thing to the nurse at the EAE. It is clinically appropriate, and it will change how the evaluation is prioritized. Point 2. Falls that seem random are often dehydration related. When the body is dehydrated, blood volume drops. When blood volume drops, blood pressure drops, particularly when standing up. This is orthostatic hypotension, and it produces dizziness, lightheadedness, and the instability that causes a fall in the 2 to 3 seconds after someone rises from a chair or bed. The fall gets attributed to the rug, to moving too fast, to general unsteadiness, and the dehydration that caused it goes completely unaddressed. If your parent has had falls, especially falls that happen shortly after standing up, ask the doctor specifically, could orthostatic hypotension from dehydration be a contributing factor? That question deserves a formal answer, including a blood pressure check, lying down and then standing, which takes about 3 minutes and is one of the most informative clinical tests for this issue. Point 3. Urinary tract infections in older adults look nothing like they do in younger people. In a young adult, a UTI produces burning, urgency, and pelvic discomfort. In an older adult, particularly one who is chronically mildly dehydrated, which concentrates the urine and creates a more favorable environment for bacterial growth, a UTI often produces none of those classic symptoms. What it produces instead is sudden confusion, agitation, loss of appetite, falls, withdrawal, or simply not acting like themselves. Dehydration does not cause UTIs directly, but it creates the conditions for them: concentrated urine, reduced flushing of the urinary tract, compromised immune function. And the two conditions together, dehydration and UTI, are among the most common and most preventable causes of emergency hospitalizations in older adults in the United States. The prevention is straightforward: consistent, adequate daily fluid intake, not heroic amounts, just consistent amounts. And I'll tell you exactly what that looks like in a moment. Point 4. Medication toxicity is a dehydration complication that almost no family knows to watch for. When the kidneys are not receiving adequate fluid, their ability to filter and clear medications from the body is reduced. Drugs that are normally processed efficiently begin to accumulate. And for older adults who are already taking multiple medications, many of which have narrow therapeutic windows where the difference between the right dose and a toxic dose is small, this accumulation can produce serious effects: lithium toxicity, digoxin toxicity, metformin-related complications, NSAIDs causing acute kidney injury. These are not rare theoretical risks. They are documented, preventable complications that happen with greater frequency in older adults during hot weather, illness, reduced appetite, or any period of inadequate fluid intake. If your parent is on any long-term medications, particularly ones that require regular blood monitoring, ask the prescribing doctor directly. Are any of these medications sensitive to hydration status? What should we watch for if fluid intake drops? That question, asked once at a routine appointment, gives you the information you need to act quickly if the situation changes. If you're finding this valuable, and I hope you are, this is a good moment to like this video. It genuinely helps this content reach other families who need it. Just tap the like button and keep watching. Checked. Point 5. The environment and habits that cause dehydration in older adults are almost entirely fixable. Most chronic dehydration in older adults is not random. It follows patterns that families can identify and change. Coffee and tea, which many older adults drink as their primary morning fluid, are mild diuretics. They contribute to fluid loss rather than fluid gain. 2 cups of coffee in the morning does not count as 2 cups of hydration. Many older adults reduce fluid intake intentionally to avoid having to use the bathroom frequently, or because of incontinence concerns, or simply because they don't feel thirsty and drinking feels like a chore. The result is that intentional restriction, added to an already blunted thirst mechanism, produces chronic underhydration that persists for months or years without ever triggering a visible crisis, until suddenly it does. Temperature matters more than most families realize. In hot weather, or in a home that isn't air-conditioned, fluid losses increase dramatically, and the thirst mechanism still doesn't compensate. Many EA admissions for dehydration in older adults happen in summer in homes that families assumed were fine, and illness of any kind, a respiratory infection, a stomach bug, even a few days of reduced appetite, rapidly depletes fluid reserves in a body that has little margin to spare. Here is the practical framework I want your family to implement. The general target for fluid intake in an older adult is approximately 6 to 8 cups of fluid per day, and that means all fluids, not just water. Soups, herbal teas, juice, milk, and water-rich foods like fruits and vegetables all count. The strategy that works best in practice is not relying on thirst. It is building fluid intake into the structure of the day. A glass of water with every meal, a glass of water with every medication, a glass of water after any physical activity, even a short walk, and a visual cue, a water bottle on the kitchen counter, a glass already filled on the table, that prompts drinking even when the urge isn't there. For families who are concerned that fluid intake is genuinely inadequate, the simplest at-home indicator is urine color. Pale yellow is adequate. Dark yellow, the color of apple juice, is a reliable sign that the body is not receiving enough fluid. This is a simple daily observation that any family member can make and act on. And one more thing, if your parent has heart failure or kidney disease, fluid targets may be different, and in some cases, fluid restriction is part of their medical management. Always confirm the appropriate target with their cardiologist or nephrologist before making significant changes. Now, let me tell you what you can do this week, because every point I've made today has a corresponding action. Today, look at what your parent is actually drinking. Not what they say they drink, what you observe. Is there a pattern of coffee in the morning and very little else? Is the water bottle untouched? Start there. Fill a pitcher with the daily fluid target and make it visible in the kitchen. This week, talk to the pharmacist about whether any current medications are affected by hydration status or have diuretic effects. Ask which ones require monitoring if fluid intake drops. This conversation takes 10 minutes, and it gives you information you genuinely need. Also this week, check the urine color next time you can. If it's consistently dark, that's your starting data point. The goal is pale yellow, consistently. This month, raise the hydration question at the next doctor's appointment. Ask whether a basic metabolic panel, a simple blood test that includes kidney function and electrolytes, would be appropriate given your parents' age, medications, and history. This is a routine test and a completely appropriate request. Ongoing. Build fluid cues into the structure of the day. Water with meals, water with medications, water after walks. A visible, accessible container of water within reach. These are not complicated changes. They are consistent ones. Here's what I want you to hold on to from today. Dehydration in older adults is silent. It doesn't announce itself with thirst. It shows up as confusion, falls, infections, and medication complications, and it is responsible for an enormous and largely preventable number of emergency room visits every year. Your parent doesn't need to feel thirsty to be dehydrated. That's the sentence I want you to remember. And the fix, the actual practical fix, is building hydration into the structure of the day before the body asks for it, not waiting, not relying on signals that no longer work reliably. Just consistent, structured, daily fluid intake as a non-negotiable habit. You have the information now. You know what to look for, what to ask, and what to change. If this video helped you understand something important about your parents' health, please share it. Send it to a sibling. Send it to a friend whose parents are in the same stage of life. Share it in a group where other caregivers are figuring this out. And if you're not subscribed yet, subscribe now. Every week I publish content exactly like this, clinical, practical, and built for families who are trying to do right by the people they love. There's a lot more coming, and you don't want to miss it. Next week, we're talking about the sleep changes in older adults that families mistake for normal aging, and the specific ones that actually signal something treatable. It's one of the most misunderstood topics in elder care, and I think it's going to change how you see your parents' nights. I'll see you there.